Okay. So male sex hormones are generally called androgens. Those include the testosterone and DHT. So we've got our terminologies. So the androgens that we're going to talk about are really all just testosterones. And then we can also talk about anti-androgens, which were exactly what you figured out, which were 5-alpha reductase inhibitors. And the way I remember propecia is alopecia is not having hair growth. And like none of us knew that word until Will Smith smacked, but because his wife had alopecia and couldn't grow hair well on her head. So remember pecia and alopecia and propecia. All right, so our overview and our learning objectives. So we talked about the androgens. Those are anything that acts at the androgen receptor. And that includes the physiological testosterone and DHT, and it also includes physiological agonists that are synthetic androgens. Where it gets confusing, and this is the first time you'll hear me say it, but I will say it so many times. I wish I ruled the world when it came to naming drugs and physiological events, because it would make so much sense. Everything would make sense. Every brand name would tell you what the drug did. It would be beautiful, but it's not. So androgens are any agent acting at the androgen receptor. As you act at the androgen receptor, you can have two different types of effects. You can have androgenic effects and you can have anabolic effects. They're both effects from the androgen receptor. So androgenic effects are coming mostly from DHT, and that's mostly the sexual differentiation tissue effects. And the anabolic effects of male sex hormones or metabolic effects are generally from testosterone. So we will talk about that in probably even the next slide. So I'm just letting you know that androgen receptors are going to, depending on whether you have DHT or testosterone, two different types of effects. And one of them is called androgenic and one is anabolic. So just to remind you, for the male sex hormones, this pathway, we talked about hypothalamus releases GnRH, the pituitary releases LH and FSH to the testes. I'm not going to make you remember which testes cells produce what, but within the testes, FSH is going to go to increase spermatogenesis and LH is going to produce testosterone production. And you're releasing both at the same time from the pituitary because guys want to make testosterone plus be able to have spermatogenesis at the same time. They don't have a monthly cycle where they want to go back and forth. The testosterone is that third hormone that gets released, and that goes to those secondary target tissues, which are going to be any tissue that responds to testosterone. The FSH is going directly into spermatogenesis. So when we talk about GnRH, when we talk about the female cycle, what tells the body to switch back and forth between LH and FSH? And really what it is it's that GnRH signal being modified. So your hypothalamus, when it releases GnRH, does not release it at once, all at once. It does it in pulses. Boom, boom, boom. It can be a few minutes. I think I wrote down in the note section what the actual pulses are in the female. It has to pulse them. If it doesn't pulse, then those GnRH receptors desensitize. So if you just got a straight up GnRH drug that didn't pulse, it would stop any activity because the GnRH receptors would be desensitized and nothing else would happen in this pathway. With males, you have to have a constant pulse rate all month. It's got a pulse, but then that keeps you then making the LH and the FSH. So the pituitary gets activated, releases LH and FSH. The testosterone that's produced is going to then go on to those secondary organs or those end organs. And those include muscle, include body hair, bone growth, as well as penile growth, like anything that you associate with male sexual differentiation. So when we saw that testosterone went to every cell, went into some cells and had testosterone effects, and other cells that went in, and if that cell had the 5-alpha reductase, then that cell would make DHT, and you'd have a DHT effect there. DHT is only produced in some cells. And that's why the effect in some tissues is mostly through testosterone, and the effect in other tissues is mostly through DHT. But it's always through androgen receptors. They're just acting different depending on which one bound. At those end organs, you're finishing the spermatogenesis that had begun. Just testosterone and DHT themselves are also having those anabolic androgenic effects. And your testosterone does that negative feedback. So GnRH pulsing causes FSH and LH. LH causes testosterone. FSH starts spermatogenesis. The testosterone comes back, finishes spermatogenesis, and does everything else that we're talking about, testosterone effects. So testosterone and DHT have those secondary effects, and then everything comes back up here. Testosterone is mostly testosterone that's going to have negative feedback. Okay, so looking again into these cells, how that's going to occur in the cell. Here you have the testes. In the testes, you have that cholesterol, made the progesterones, made the testosterone. That's what gets released into the circulation, that T. If they go into cells that have the androgen receptor, but don't have 5-alpha reductase, that's a cell that just wants to use testosterone. That's all it wants to use. So the testosterone binds the androgen receptor, that causes gene transcription and causes anabolic effects. So those are, I think of anabolic as metabolic. That's my hint to my brain. So cortisol, muscle, bone, brain, red blood cells, things that I can kind of think about being like I'm exercising. On the other case, when T goes into cells that have 5-alpha reductase, then before the T acts, it gets turned into DHT. That's quick. So you're gonna have mostly DHT activity here, a bunch of DHT that binds the same androgen receptor, but it makes it shape differently, so it goes in and it produces different proteins. And those are proandrogenic, and those are kind of sexual characteristics, like genital growth, effects on hair follicles, sebaceous glands, prostate cells, things like that. I drew my husband here. He deserves to be in my lectures. The way I remember it is because the androgenic effects are more anatomical. I remember DHT is androgenic. Okay, here's where we differentiate between the testosterone-like and the DHT-like effects. The testosterone-like, we said we're anabolic. We call these effects anabolic, and they're really growth and metabolic functions. And the DHT causes androgenic effects, and those are mostly sexual characteristics. All of these act through the androgen receptor. The anabolic effects are going to be things like we're going to see decreased cortisol production and cortisol with sweat, the what hormone? The stress hormone. We see increased muscle mass in general, and all this is a spectrum of how much. Not every guy has massive muscle mass, and not every woman has low muscle mass, but increased muscle mass by testosterone. A lot of times what you'll see is increased ability to gain muscle mass. So it's easier for guys to build muscle mass than for women usually. Testosterone is going to stimulate red blood cell development. You can have a higher hematocrit, and it increases bone length growth during the time that the long bones are able to grow. So during adolescence and in guys their early 20s. Right after the long bone stopped growing, it stopped growing. And no amount of testosterone is going to increase height as an adult. When you look at this, these metabolic type things, I think of increased bone growth and muscle mass and red blood cell and cortisol, if I think in terms of a cyclist. I remember, you guys probably don't even remember Lance Armstrong, but he like got caught like taking too much anabolic steroids. And they were like, well, dude, now your body doesn't respond to stress as much. You build muscle more easily. You have more hematocrit, so you are able to use oxygenation better while you're cycling. And he was already an adult, so he didn't get increased bone length. So that's kind of what I remember. I remember Lance Armstrong when I think about anabolic effects. Then we go to androgenic effects. And we can see enhanced sex drive and libido. DHT can also cause increased aggression. And to my guys, whom I love, this is true. We can see it in humans, we can see it in rats, but unlike rats, humans can learn. So I know all you guys got it under control. But it's very interesting because when you do give female rats that have estrogen blocked and you give them DHT, they start humping the other rats and they start fighting like crazy. So it really does have a clear effect hormonally. And I know people who have started taking testosterone replacements and testosterone therapy and said that they felt these increases in aggression and stuff like that. They just had to learn how to, the androgenic effects like DHT-like effects. When I think about those effects that are occurring in puberty, I'm thinking about acne growth, beard and body hair growth, and hopefully not in puberty, but later on in life, male pattern baldness. And this is what sometimes confuses people. Beard and body hair increases growth and head hair can decrease growth. So it's just how the different tissue responds. Head hair tissue may or may not decrease growth, and the beard and body hair usually will increase growth. Also, we've got development and maintenance of male sex organs, both in utero and then during puberty and spermatogenesis, and an increased size of the prostate. Okay, if you take an androgenic drug, whether it's testosterone or whether it's a synthetic replacement type drug, you're going to see adverse effects. And they're dose dependent, just like every other adverse effects. If you are giving testosterone or testosterone replacement, your adverse effects are going to be testosterone adverse effects and DHT adverse effects. If you're replacing testosterone and you're increasing that, then you're also increasing DHT. And you're also, in some cases, increasing estrogen as well, just because you're flooding the cells with too much T and enzymes. So if you're giving DHT only, you may not have as many ADEs, but you'll still have the ADEs that came with the DHT. If you give T, you're going to have all of the ADEs. I'm going to call it just AR agonist ADEs, which are both androgenic and anabolic effects. You can have gynecomastia. So let's say someone is taking, let's think about it like too much. Let's say someone is taking illicitly pro-testosterone agents for muscle mass, and they're taking a huge amount of them, and they start to grow breasts. Why are they growing breasts when they're taking a testosterone? Mm-hmm. You guys agree? Because if they're taking a lot of testosterone, you're going to start making some estrogen too. Priapism means an erection that will not go away. And this is actually I was going to say it's way worse than it sounds. It sounds pretty bad, but it can be very dangerous because with the erection, it's decreasing blood flow, and you can actually have tissue necrosis in the penis from decreased blood flow from an erection that lasts too long. So when you look at things like they say with Viagra and stuff like that, if you have an erection that lasts more than like 4 hours or whatever, go to the emergency room. They mean it. Hirsutism, do you guys know what hirsutism is? Hair growth, yeah. Acne and aggression, those are those things that we were looking at as the androgenic effects. Testicular atrophy and low sperm counts. Let's look at that again. Hypothalamus, pituitary, and then went to the testes. The testes made the testosterone, and the DHT comes from that. So now what we're going to do is we're going to give a ton of testosterone, say. What it's going to do is it's going to come back and it's going to block GnRH, it's going to block LH, and it's going to block FSH. So you're not going to start spermatogenesis. So that testicular atrophy and low sperm counts are coming from too much testosterone causing the whole pathway to start to be shut down from feedback inhibition. We can see precocious puberty in children. If you read the warning labels on testosterone androgen agents, you can see testosterone effects and precocious puberty in kids that are like 6 years old. So they're pretty serious when they talk about don't let these drugs get in contact with kids. And then similarly, unwanted masculinization of females who are in contact with these drugs. So we already kind of answered why would you see a low sperm count? That's because of that negative feedback. And men can get breast cancer as well as women. They have all the same tissues, they just haven't grown as much. If men get estrogen at higher levels, their breasts grow. So all of that is still there. And men can get breast cancer as well because the same cells and tissues are there. They're less likely to get breast cancer because they don't have as much estrogen. So those cells aren't really growing. Say you have a man who did get a breast cancer and he might be like, okay, well, it's a breast cancer, so I don't want estrogen, I'll just take tea. What could happen there? Taking the tea, it can also increase your estrogen production. So tea supplementation would be contraindicated in a male with breast cancer because you'd be bringing that estrogen effect in. Okay, pro-androgen drugs, it's basically testosterone. You are so lucky. Because when we get to the estrogens and progestins, you're going to be like, I hate this. But testosterone is basically just testosterone. Most of the sex hormones, they're steroid hormones. They don't have good oral bioavailability. If you are going to use unmodified sex hormones, they generally have to be at a very high dose. So the real idea has been most pharmacology, most drug has been modify those hormones. So we do have testosterone replacement therapy. The indications are for gender affirming therapy to create a male physiology and for hypogonadism for men who have low synthesis of testosterone or no synthesis of testosterone. That can be because testes were damaged in an accident or testes are damaged or just not really super functional from development. It can be because someone has damage to their hypothalamus or pituitary. If it's not releasing GnRH or LH and FSH, you're not going to make testosterone. Some brain injuries can actually affect your sex hormone production. So some damage can reduce the testosterone levels, and testosterone levels just decrease with age. The mechanism of action for these, they're just androgen receptor agonists. Unmodified T has a very poor oral bioavailability. And what's interesting here that you'll be talking about a little bit is the androgenic anabolic ratio. If you have a drug, though, that comes in and is an exogenous androgen, it might have a varied amount of anabolic versus androgenic effects. What we want to do is we just say anything that mimics your natural androgenic to anabolic ratio in your body, we're going to call it 1:1. Any drug that we give that increases androgenicity over anabolic, it's going to be like a 2:1 or whatever. Anything that increases anabolic over androgenic be like a 1 to 2 or whatever. If you want to mimic your natural effect, natural physiological effect, you want a drug that also has a 1-to-1 ratio. If you want to do bodybuilding and you just want to increase muscle mass, you might want one that has a higher anabolic effect than androgenic effect. So generally anything that you're going to be seeing, you're going to be wanting it to be the closest to a 1-to-1 as you can. Because it is affecting real time the growth of the cells, anything that requires cells to continue growing, like keep making body hair, and you want to keep that on board. Anything that was like happened during fetal development or puberty, like say increased long bone growth. Once that's happened, it doesn't matter if you take it away, the hormone away, that's happened. It depends on which tissue you're talking about, whether that effect stays or goes away if you go off of testosterone. So yeah, so for gender affirming therapy, it really matters whether you are taking it during puberty or after puberty, because all those things like long bone growth and your voice changing and things like that are anatomical things that change with male puberty. If you have this higher testosterone levels during your puberty, it's going to go that direction, and that would be a permanent change. But the other things that are kind of just upkeep in your body will go away if you go off a gender affirming therapy. What's an anatomical change that once it's done sits there versus what are the changes that are going to continue to change? How much hair do I make? How many red blood cells do I make? How much muscle mass can I make? Those are going to be depending on what's dependent on what you have right now. All right, so we are going, we're going to finish up the androgens. I said that really the androgen drugs are just forms of testosterone. The ones that you most often see are actually going to be unmodified, and that's because they're not oral. So if it's not going to be orally given, if it's going to be a patch, a spray, or a gel that's dermal, you can use testosterone itself. And so I'm not going to have you memorize for me the different brand names, but I think they're pretty easy to remember. The gel is called Androgel, and Axe Iron makes perfect sense because it's like Axe body spray. There's some injectables. That's what I've seen people who are do gender affirmation therapy using injectables. You'll see that unlike the dermals, which are not derivatives and are just going to be testosterone, these are going to have a derivative name on them. And then there's a PO derivative. What I want you to do is just be able to tell me, what's dermal, spray or gel, which ones of these testosterones are injectable and which one is PO. The box warning for Androgel is pretty clear for inadvertent secondary exposure to children. And so they're talking about gel products, but that would really be any dermal testosterone would do the same thing. And there's a box warning for effects in children 9 months to 5 years old of aggressive behavior, increased libido, genitalia enlargement, advanced bone age, and premature development of pubic hair. So that's a pretty significant concern and safety issue when using these agents. The anti-androgen agents, you already probably have figured out most of them from our synthesis. We've got agents that inhibit all androgen and estradiol synthesis. We've got agents that inhibit only DHT. Why would you give a 5-alpha reductase inhibitor? Have male pattern baldness and prostate enlargement. The CYP17, if you were really trying to block all of these, can you have cancers that are just multiple hormone sensitive?
Yeah.
Yeah, you can have cancers that are sensitive to a lot of hormones. In that case, you really might want to inhibit testosterone, DHT, and estradiol, all 3 of them. Okay, so we have those DHT synthesis inhibitors. You guys already know how these work. The molecular mechanism of action is inhibiting 5-alpha reductase. The cellular is to decrease DHT production, and the clinical would be to reduce androgen effects on prostate and head hair. And then the drugs are dutasteride and finasteride. It's interesting because the dutasteride is really only used for benign prostate hyperplasia. Proscar and Propecia are the same drug. It's just a dose difference. So Propecia, alopecia, is the hair, and Proscar is prostate. So that'll tell you which one you're using it for. And these guys, since they're DHT synthesis inhibitors, are going to have anti-anabolic effects, because DHT caused the anabolic/metabolic effects. So a DHT inhibitor is going to reduce those. So you're going to have, if you were in puberty, reduced bone growth. You're going to have decreased, it'd be harder to make muscle mass, harder to get your hematocrit up. Those things that we were talking about, anabolic effects, you're going to have less of those because you're blocking the DHT. This also has a pregnancy warning. Do you guys know the pregnancy warning X? Known to cause harm. Right, that's like the pregnancy warning. For pharmacists who are pregnant, are you allowed to handle these pills?
No.
Women who could become pregnant are not even allowed to handle these pills. That concern is so high. So knowing what these drugs do, why is this an issue? It can cause birth defects. Think about what these drugs do. What type of birth defects could be caused? Abnormal development of any male anatomy in the fetus. So one of the effects can be unwanted feminization of an XY fetus. So if you're blocking production of DHT, the male fetus is not going to start developing anatomically male. The prostate is normally in the male around the urethra, the upper part where it's coming out. The prostate is just kind of like around it. And so there's the tube, and prostate's just sitting around it, no problem. But if the prostate starts to swell, it's just going to impinge on the tube. And so it's like super simple. It's like it swells, it just pinches the tube and makes it harder to pee. Benign prostate hyperplasia means hyperplasia growing too much, and benign meaning it's not a cancer. So this is not how you would treat a cancer, like just give them dutasteride. No. So this is to treat the swelling if that's what's causing difficulty urinating. And you'll talk about that with Dr. Gordner, I think. And the 5-alpha reductase. There's not a ton of actual evidence that women who are pregnant, like of how likely it is to have birth defects, but it's like they're just not risking it. And you're not going to do human studies anyway. Like that would be a bad human study. Here, you're pregnant. Let's give you a placebo or dutasteride. We don't live in the 70s anymore. If you got that, That was a human studies research joke.